Hello everyone and welcome to today's Physio TV session. In the Physio classroom today, we'll be going through a quick shoulder assessment. Before that, hi, I'm Siddhanth Sawant. I'm an assistant professor at Sanjiti College of Physiotherapy and I'm thankful for the Physio TV team for giving me this opportunity. So, coming back to the topic, and before we starting off the shoulder assessment, let's just understand what we mean by shoulder anatomy or the shoulder complex per se. So when I talk about shoulder complex, I'm talking about basically 4 joints. That includes your sternoclavicular joint, acromioclavicular joint, the glenohumeral joint, and another joint that is formed between the scapula and the thoracic cage, that is the scapulothoracic joint. So when we talk about the motions happening at these 4 joints together is what I understand by a shoulder complex motion, and we have to try to assess this complex and how can we ease out the process. It is what will be the agenda for today. So when I talk about the shoulder complex per se, what will be the resting position of the glenohumeral joint to start with? So for glenohumeral joint, the resting position is around 40 to 55 degrees of abduction and around 30 degrees of horizontal adduction, whereas the close pack position for the same is with full flexion, with full abduction and lateral rotation. On the other hand, the resting positions for your acromioclavicular joint and sternoclavicular joint is arm by the side. When I talk about the history part of it, when I talk about taking the history per se, your history itself tries to give you some amount of differential diagnosis. Let's take an example. Let's start with, say, the age of the patient. So when I talk about the age of the patient, it is around, say, that if the patient is around 40 to 65 years of age. So one of the commonest diagnoses that should pop up in your head will be a rotator cuff degeneration. On the other hand, if somebody is just above 35 years of age and complaining of pain right on the superior aspect of the shoulder, a diagnosis that can pop up in your head or could be a part of a differential diagnosis on a priority list, that could be a primary impingement. If a person of similar complaints come to you with, say, at a very early stage in life, that is around late teens or say 20s, early 20s, and has an history of say sports or athletics, the diagnosis that needs to come in your head or say on priority basis, that could be a secondary impingement. Having said that, when I'm talking about the age, something else also matters, which is pain. Now, from the pain perspective, in the history, I generally ask for, say, extent or behavior of pain and aggravating and relieving factors which play a very important role in this. Apart from this, how long the pain has been. So is the injury chronic, is the injury traumatic or acute? Okay, that is what we need to observe. Followed by that, when I move on with my other questions, since we are dealing with upper extremity, the thing that we always look out for is dominance. So dominance also plays a very important role in conditions. After that, along with that, when I'm talking about a history per se, and we will be observing that as well. So when I'm talking about the history, a history of trauma basically helps us to understand if there has been any nerve injuries with these patients as well. So in cases of that, of course, we will be having equally or similar findings and observations if the history is of nerve injury as well. So having said that, these are the few queries which you can, or these are the few questions which you can ask the patient, which will help you to at least give you the list of differential diagnosis, on which then we can start coming down or say condensing down to a single diagnosis. Before we move on to the special test, let's just start with what we'll be seeing on observations. So before moving on with the observations, let's just start with the palpation of the shoulder joint. For that, we have Mr. Rohan Agamane with us, who has volunteered to become the model. So we thank him for that. So starting with the palpations, I always start from the midline of the body. So from the sternum, you can always palpate laterally on the clavicle. Once you move laterally, what you find is the highest point, which becomes your acromioclavicular joint. Now from the acromioclavicular joint, we start palpating posteriorly. So palpating the clavicle posteriorly onwards, now that we are already on acromioclavicular joint, we start palpating the spine of scapula posteriorly. always remember to just ensure that you're exactly in the spine of scapula by doing a vertical motion around it, by moving the fascia around it. And the first depression that you find out at the spine of scapula is the root of spine or the base of spine. Okay, once we have palpated the base of spine, I always go inferiorly to palpate the inferior angle. So once you go in a straight line and the first contour that you encounter is basically your inferior angle. Now after the inferior angle, you come back to the root of spine and you palpate it superiorly. While palpating superiorly, just ensure that you're not irritating the trapezius. One of the common conditions which all of us are facing is a trapezitis, or say a spasm in trapezius, if not trapezitis then. So there is some amount of spasm which is always present in the trapezius, which now has with the research has been said that it's postural and it's normal. So just ensure that you're not irritating the trapezius and make sure that the first contour again superiorly you find out becomes your superior angle. I'm so very sorry for that. So this is how you palpate the scapula and the clavicle. Okay, so after palpating the clavicle and the scapula, we move on to the humerus. So as we have already discussed how to palpate the AC joint. So once we are on the AC joint, we come laterally further, okay, and the first when the first landmark that you observe, okay, is your greater tubercle. But how do you confirm that it's your greater tubercle? What you can do is you can keep your one hand on the landmark that you have achieved and you can just perform a gentle rotational motion at the shoulder joint. Once the landmark, okay, or the bony contour that you have reached is moving along the lines of rotations, automatically that becomes your greater tubercle. Now coming back to the observations, what do you observe basically on your anterior view? First we discussed that. So the first thing that we always need to observe anteriorly is the clavicles. Are both the clavicles at the same height? And if any of the clavicle has been raised, if the clavicle, if you feel, is raised, always palpate the clavicle laterally and observe for if there has been a step that is seen. So what do I mean by step is whenever you palpate or whenever you visually follow the clavicle, after the clavicle ends, there is actually going to be a depression and then the shoulder contour will continue again. In these conditions, it's generally because of an AC joint dislocation, which is very common. Okay, so that is what your step deformity says. After that, you can also see a sulcus sign. Okay, a sulcus sign is generally seen on the capsular areas. So it's nothing but an inferior subluxations of your glenohumeral joint. How do you differentiate between step deformity and sulcus sign? One of the commonest ways of differentiating between the two is the clavicle is always inline or bilaterally symmetrical in a sulcus deformity. There is no reason for clavicle to move in a sulcus deformity, whereas for a step deformity, the clavicle has to move. So you never see clavicles bilaterally symmetrical. So that's one of the major differences between sulcus sign. Now moving ahead in the posterior view. So the next thing that we need to observe in the posterior view is something called as the Lenny test. The Lenny test is nothing but the distance between the scapula and the thoracic spine. So what you need to do is just palpate the thoracic spinous processes down, okay, and corresponding to the thoracic spinous processes with the three landmarks that we have already seen. One is your root of spine, one is your inferior angle, and one is your superior angle. So the thoracic spinous processes which are corresponding to these three landmarks needs to be marked on both the sides, and all you need to do is just observe the distance with the corresponding spinous process and the superior angle, the corresponding spinous process and the root of spine, and corresponding spinous process and the inferior angle of one side, and the similar thing on the other side as well. Okay, that is what your Lenny test is. The next thing that you need to observe is your winging. Okay, so for winging, you can observe both as static as well, and when we are asking the person to move the limb. Okay, so when we always request for checking the winging, dynamic winging, we always request the patient to go ahead and perform bilateral abduction of the shoulder. So we request the patient to perform bilateral abduction of the shoulder. Let's go ahead. Can you please perform bilateral abduction of the shoulder? And you have to just observe the movement of scapula, and if the winging is seen in that as well. Thank you so much. So that's your winging and posterior observations. So moving ahead with the palpations part of it. So what do I palpate generally? Okay, so as we have discussed how to palpate the greater tubercle, so I go ahead with the clavicle, I palpate the greater tubercle, I ensure that I am on greater tubercle with the rotational component. And once I am on greater tubercle, I always check for tenderness around the greater tubercle. So a tenderness around a greater tubercle generally suggests anything to do with the rotator cuff, because that's where they insert. On the other hand, if the tenderness is around the joint capsule, and moreover anteromedially, okay, anteromedially there is a joint capsule tenderness, it generally talks about a labral tear. Again, after that, if I'm talking about anywhere on near the transverse humeral ligament, I'm basically talking about a bicipital tendinitis. But again, you need to remember while doing this is just on palpation that the pain or that we are finding a priority diagnosis. So this is just a part of differential diagnosis, and this will be helping us to reach to a final diagnosis. This is not the final diagnosis. Just remember that. So it's just helping us to make the priority lists of our differential diagnosis. Many a times in conditions like a rotator cuff tear, there has been seen bicipital tendinitis as well, where the biceps is trying to protect the shoulder joint. So just remember that it could be 2 or 3 conditions put together as well. Talking about palpations further, I always palpate for the rotator cuff bulk, okay, which is present over here. And after that, if there is any tenderness around that line, and one of the common sites of triggers which I always palpate is for the latissimus dorsi, which basically forms the lateral lip of the axilla. So since the fibers twist over there, that is one of the common sites for triggers which you see. After that, there are also common trigger points on the medial aspect or the medial border of scapula as well. So even that is a common site for palpation of trigger points. Lastly speaking, whenever I palpate the spine of scapula and the clavicle, the area between that lies the supraspinatus fossa as well, just below the upper trapezius bulk. So just laterally where these two are meeting or about to meet, you can palpate your supraspinatus, and generally the patients with conditions of supraspinatus getting involved, they get a tenderness which is present over here. So now we move on with the next part of assessment, that is the special tests basically. So the first one is going to be the apprehension test. In that apprehension test, we'll be discussing about posterior and anterior apprehension both. Talking about anterior apprehension test now, for that the patient is in supine line, and we abduct the shoulder and we go ahead with lateral rotation. We check for any pain or any sudden movement from the patient or apprehension per se from the patient, and if the patient is not giving any, so then we go ahead with the second part of the test, that is we place our fist just below the head of the humerus, giving it an anterior bulge and going ahead with your lateral rotation motion again. And if again in this the patient is not showing any apprehension, then the test is considered to be negative. I repeat, this test needs to be performed only with patients where there is a history of subluxation. Otherwise, we avoid doing these tests. So as said, when we are talking about apprehension tests, the first one amongst that is going to be the posterior apprehension test. So in posterior apprehension test, the patient is in prone line, and what we need to do is we just need to abduct the arm slightly. I'm going to place my hand just anteriorly over the head of the humerus, giving it a posterior bulge to the head of the humerus, and I'm going to perform medial rotation. So it's abduction with medial rotation put together, and if the patient complains of apprehension of a sudden stopping of the movement, then the test is considered to be positive. I have to mention one point over here, that is, these tests are generally performed with patients complaining of any subluxations before. Generally, otherwise, we do not perform these tests on priority basis because these tests are known to cause subluxations as well. So you have to be very, very careful while performing these tests. Okay, going on with the next part of anterior apprehension test. We performed the one in supine just a while ago. We'll be doing the same thing in standing as well. So for that, we take the patient in standing. We are standing by the side of the patient slightly posteriorly. We are going to, with one hand, we are going to abduct the arm and we are going to go for a 90-degree abduction. With my second hand, I'll be placing it on the head of the humerus and I'll be giving a gentle anterior thrust and I'll be performing a lateral rotation motion as well. If the patient complains of apprehension in this position, the test is considered to be positive. So moving on with the test for labral tears. Now we have already discussed on palpation that generally when I'm palpating on slightly on the anterior medial aspect of the glenoid fossa, and if the tenderness is present over there, then I move on with the labral tests immediately. So while performing the labral test, I generally choose O'Brien test, and while performing the O'Brien test, we start with the patient is in standing position. From the instructions per se, we request the patient to flex the arm till 90 degrees. Then we request the patient to slightly adduct the arm till 10 degrees, and we then move on with the internal rotation motion at the shoulder. Once the patient has achieved this position, we request the patient to hold this position against our resistance, which will be in the downward direction. So I request you to hold the direction and I give a gentle downward pressure, and if the patient complains of pain in this position, I move on to step 2 of the test. In the step 2, I maintain the adduction. The only component I change is that of external rotation. So now that the patient has maintained the external rotation component, I am going to give gentle amount of resistance in the downward direction. You have to maintain the hand against my resistance, and if the patient responds with less amount of pain, only and only then, or if in the step 2, if there is no pain at all, or the pain disappears, automatically the test is considered to be positive. So that's your O'Brien test. We now move on to the next part. Which is your tests for any muscle pathologies. In this, the first one we talk about is the empty can test for supraspinatus injuries. In this, we take the patient in standing. We are standing again in front of the patient. We request the patient to take the hand slightly in abduction. Now, in this position, okay, we explain the patient about the scaption plane, and we maintain the arm in scaption plane. After this, we request the patient to take the arm in internal rotation. I want you to rotate the arm inwards. Okay, very good. We ask the patient to maintain this position against our resistance. So all you need to do is just maintain this position, and I'll be giving a downward resistance to you. So maintain this, relax. And we try to, now you can keep the hands down. We try to perform the test bilaterally because it's always easy for the patient. And if the patient complains of pain in this position, automatically the test is considered to be positive. So the next test in the muscle pathology is the drop arm test. The drop arm test is generally performed for your rotator cuff injuries. So how do you perform this test? So you're taking the patient in standing. You're standing slightly behind the patient posteriorly. My one hand goes on the scapula just to give cueing. With the other hand, I abduct the shoulder of the patient, and I request the patient to slowly take the hand down. So all you have to do is just slowly lower the arm down. Okay. In an ideal scenario, I'm supposed to leave the hand completely, but I always stay as close as possible with the arm without touching it. Why does it help? Is because if there is any incidence of dropping of the arm, automatically I'm there to hold and to support the arm. So in this case, since the model is normal, where the test is negative, in an ideal scenario, okay, where the test is positive, the patient tends to leave the control of the arm completely, and that's why it's called as a drop arm test. In this, we can always mark the painful arm as well during the test. The next test in the muscle pathology list is for your subscapularis. For your subscapularis, I generally perform the abdominal compression test. So for the abdominal compression test, the patient is standing. The therapist is standing just besides the patient. I ask the patient to keep the hand on the abdominal. Now, while taking this position, ensure that the arm, the forearm and the wrist are in one line, and making sure that the shoulder is not in protraction and in one line. While maintaining this, you gently place your hand between the stomach of the patient and the hand of the patient. With one hand, I'm going to keep it on the scapula to just give the cue, and I'm going to ask the patient to perform an abdominal compression. Now in this, you have to notice that the patient is not using any of the extensors or the flexors of the forearm. Along with that, the patient is not causing any protraction motion as well. When the motion of the internal rotation happens purely and the patient complains of pain on the anterior aspect anywhere, then the test is considered to be positive for subscapularis. The next test for in the muscle pathology list is for rotator cuff test. So what do I perform is the patient is standing, and as a therapist, I'll be standing right in front of the patient. The arms are flexed till 90 degrees, sorry, the elbows are flexed till 90 degrees. I ask the patient to make a fist of the fingers. I always keep the thumbs straight so that I come to know if there is any wrist motion happening at the joint, which is very easy to identify. After that, I'll be asking the patient to perform the action of external rotation, and I'll be giving the resistance against it. It should be an isometric action of the muscle. So all you need to do is, I'll be placing my hands behind on the wrist, okay, and all you have to do is just give pressure against it, okay. So let's go ahead, perform, and while performing this, just ensure that the patient is not protracting too much, because then he'll be using his body weight unnecessarily. With this as well, the second thing that you need to observe, relax. The second thing that you need to observe is the position of the thumb, that the patient is not using the wrist extensors while performing the external rotation motion. With that also, the test can come false negative. On the other hand, how do you say the test is positive? If the patient complains of pain on isometric activations of the external rotators, then the test is considered to be positive for infraspinatus and teres minor. The next part of test is for bicipital tendinitis. In this, we perform generally two tests. One is Speeds and one is Yergason's test. For Speeds test, what we do is we ask the patient to flex the arm till 90 degrees from the shoulder, maintaining the shoulder elbow in extension, and I ask the patient to supinate the arm completely. Now I'm going to ask the patient to hold this position against the resistance. I'll be giving you slight downward resistance, and you need to hold this. So let's go ahead. If the patient complains of pain in this, we move on to step 2, and we are going to slightly pronate the arm and pronate the forearm, and then we are going to perform the same test again. If the patient complains of no pain in this, in the second position, only and only then the test is considered to be positive. This was your Speeds test. We move on to the next part, that is your Yergason's test. For Yergason's, what we do is we flex the arm, flex the elbow till 90 degrees. We go ahead with medial rotation and pronation of the forearm. Now the action that you need to perform is you need to supinate and laterally rotate at the same time, okay, making sure that the shoulder is in line. We start the test. What are we going to do is we'll be giving him resistance in that motion, okay. So all you need to do is perform lateral rotation and supination. Go ahead, go ahead, go ahead, go ahead, go ahead. Relax. If the patient doesn't complain of pain in this position again or during this test, the test is considered to be negative. On the other hand, the thing that you always need to remember is that the patient is not protracting the shoulder at the same time. If the patient is protracting the shoulder, the test can come false positive or false negative. So the next set of tests are the tests for impingement. Generally, the patient complains of pain during the time of abduction superiorly, just below the AC joint, because that's where the subacromial arch is and that's where the actual impingement of supraspinatus happens. So if this is the complaint, then I always move towards my impingement tests first, which are two. One is Neers and the other one is Hawkins-Kennedy. So the first one, while performing Neers, is my one hand is placed gently on the scapula. The other one is placed distally on the radius. Taking a good grasp, I internally rotate the arm and all I'm going to do is perform the action of flexion and I'm going to take it down. Okay, this action needs to be performed immediately without patient knowing, so that if the test is positive, we come to know and there is no guarding from the patient per se. If the patient complains of pain or if the patient doesn't allow you to perform the test completely, automatically the test is considered to be positive. On the other hand, the next test is the Hawkins-Kennedy. For Hawkins-Kennedy, I flex the shoulder till 90 degrees. I'm supporting the arm at the distal end. With the other hand, with the testing hand, I'll be holding it at the distal end radius and I'll be performing a quick internal rotation motion. This quick internal rotation motion, if the patient complains of pain in this, the test is considered to be positive. Lastly, the next test that we'll be talking about is going to be your scapular retraction test. Why do I generally perform this test? It basically helps me to rationalize the part of a retractor strengthening in the management. So while performing this test, we ask the person to abduct the arm voluntarily first. So I request you to abduct the arm how much ever you can. Once the patient has performed the abduction range, you notice and you observe the quality of movement, the history of pain and the winces if the patient is doing any. After that, what we do is we place one hand on the scapula such that your metacarpal heads are placed on the spine of scapula and we are giving a gentle downward push or the inferior glide. With my thumb, I'll be giving a retraction force and with the palm, I'll be giving a gentle posterior tilt. What are we doing? We're trying to correct the position of scapula. So we correct the position of scapula by this and we ask the patient to again perform the same motion. So when the patient performs the same motion actively, take it down now. Relax, relax, relax. Good, good, good. When the patient performs the same motion actively, if there is less of pain, if there is a increase in the range of motion, if there is a disappearance of wincing from the motion, automatically the test is considered to be positive and basic strengthening and stability exercises at the scapula will definitely benefit the patient in the management. So with this, we come to an end towards our quick shoulder assessment. When I talk about functional assessment as well, just to give you few hints, suppose if I'm while during the time of history, the patient complains of say pain while pulling the hand up, I generally check for bicipital tendinitis first, or say if the patient is complaining of pain while making the hair, I automatically start checking for rotator cuff primarily. So these are the few hints that you need to remember when you're taking the history from the patient. On the other hand, when I'm talking about functional assessments, scales per se, there are two which are generally used. One is PADI and one is DASH. They have their shorter versions as well which are available, which are equally validated and reliable. One is short PADI and quick DASH respectively. So with this, we come to an end of a quick shoulder assessment. I hope it was informative and easy for you to perform in the clinics as well. With this, I would like to thank our chairperson, Parag Sancheti sir, and Manisha Sangvi ma'am for giving me this opportunity, and our principal sir, Dr. Apurva Shimpi sir, for helping me out with the entire presentation. And at the end of the session, I would like to give my regards to the Physio TV team, my model, Mr. Rohan Agavne, and the viewers, of course, you guys. So thank you so much for listening, and I hope you had a fun session. Hope to see you soon. Thank you.